After. Okay. Thank you very much for the kind introduction. Assalamu alaikum, sabah al-khair. Thank you very much, dear Mother, first of all, for the kind invitation to come to Baghdad. It's a real honor and a privilege to be here in front of you all today. And dear Professor Abdul Hamid for the kind introduction in the morning as well. So I have no conflicts of interest with regards to this first talk, but what I will say is that I'm not a radiologist. And I think this is important because particularly in pleural disease, one of the key things that's happened over the last 10 to 15 years is that physicians have really taken ownership and pushed forward the clinical utility of imaging in pleural disease and are certainly driving a lot of the research that is taking part at the moment, particularly in terms of MRI and PET. These I will not cover today because they are very much still within the research realm. However, I will focus on ultrasound and CT, which are really the major workhorse behind everything that we do in pleural disease. So I'm going to start, first of all, by covering some aspects of CT in terms of diagnosis and intervention, and then the majority of my talk will be focused on thoracic ultrasound. So first of all, with CT, what is the main use of CT in pleural disease? Of course, it allows guidance of pleural biopsy, particularly in difficult cases where there is difficult pleural thickening, difficult pleural drainage placement required. Secondly, in being able to identify and characterize the pleural thickening in terms of the nature of it, some of the characteristics that allow us to define the etiology of the pleural thickening, whether it is benign or malignant, and we will come to some of these later on in the talk. Also, sometimes it's very tricky on ultrasound to identify whether collections of fluid are based parenchymally within the lung or they are whether they're in the pleural space, and CT is key in helping us to differentiate this, although sometimes it can be difficult to differentiate a lung abscess from a pleural empyema, for example. And then finally, it allows us to identify any amount of air at all in the chest, where sometimes, obviously, chest X-ray, being a 2D structure, can have significant limitations in that respect as well. So there are two key points when it comes to doing the right CT scan to ask the question about pleural disease. The first one is whether you need to drain all the fluid. There used to be this preconception that if a patient comes in breathless with a pleural effusion, that you need to drain all the fluid first to allow any abnormalities within the lung, such as tumors or cancers, to be seen. And we did this study in Oxford. This was led by my friend and colleague, John Corcoran. And what we did was we took 32 patients with pre and post drainage CT scans, and actually we had our radiologists blinded and to double reporting the scans pre and post, and there was no additional information gained by draining the fluid. So actually you do not need to drain. If the patient is symptomatic, of course, perform a therapeutic aspiration to relieve their symptoms, but there is no need to specifically admit the patient to drain all the fluid before you do the CT scan. And this is important because this allows us to facilitate the outpatient diagnostic pathway, so the patient does not need to be admitted to hospital to have this done. The other important thing is for this CT scan, for example, this was a CTPA. This was performed in arterial phase contrast. And then the reporter of the radiologist reporting said there was no evidence of malignant pleural disease. However, because the history and the clinical picture was very suspicious, we asked the patient to reattend and to have another CT scan performed in the delayed venous phase, which is specifically the pleural phase of contrast, where the contrast is injected 60 to 90 seconds after. And what you see is you get some very different, if my laser can work, I think this is a mouse maybe rather than a laser, but you can see here that you get some new abnormalities appearing here in terms of pleural thickening involving the mediastinum, which are very suspicious for pleural disease, which were not evident on the original scan. So that's why it's really important to have the CT performed in the right phase, and also make sure your radiologist knows what you're looking for when the scan is performed. And then again, the nodular pleural thickening is shown there. So what are the key things that we're looking for when we're trying to identify features of pleural malignancy? These are the famous Lyon criteria. They have been with us now for nearly 35 years. And these are the key things that we're looking for when we are looking at our CT scans, trying to understand the etiology of pleural thickening of malignancy. We're looking for circumferential pleural thickening involving the hemithorax. We're looking for any evidence of irregular pleural modularity. We're looking for pleural thickening of above a centimeter and any mediastinal pleural involvement. And when we see these things, we have to be very suspicious as to whether there is any malignancy involved behind the etiology of the CT scan. Now, how good is CT? Now, I've given you these criteria, but how good is CT at reliably identifying pleural malignancy? So again, my colleague Rob Halifax performed this study. These were 370 patients undergoing thoracoscopy, which obviously is the gold standard for pleural biopsy to identify malignancy. 57% of these patients had malignancy. What we did was we looked back at the CT reports, and what we found is actually that the CT reported malignancy in only 144 of the cases, giving a sensitivity of 68% and a specificity of 78%, which means if you look at the negative predictive value, a third of your patients who have a CT report that says no malignancy will actually have evidence of malignancy. So it's really important to understand this limitation as well. And if there is any suspicion, then you do need to proceed to a pleural biopsy. So what about CT in pleural infection? Obviously, parietal pleural enhancement. You can see there the famous split pleurosign, which a lot of you will be aware of. This is involvement of the visceral and parietal pleural enhancement on CT scan, very suspicious for an empyema. You also get evidence of enhancement and thickening of the extrapleural fat and soft tissues, which you tend to see with benign etiologies of pleural thickening as opposed to malignancy. Again, one of the advantages of CT, as I mentioned, is allow you to assess the lung parenchyma, looking for any evidence of coexisting, for example, consolidation or ground glass changes or anything like that, as well as being able to distinguish lung abscess from empyema. So that concludes my section on CT scan. Those, I think, are the key takeaways. So it should be considered the primary modality. If you need cross-sectional imaging, CT is your friend. Interpretation requires clinical correlation, and you should really be aware of the limitations, especially with ruling out malignancy, and make sure your radiologist performs the CT in the right phase, depending on what you want. Okay, so thoracic ultrasound does the same things, allows us to characterize thoracic disease and helps us with intervention. But let's look at how it does this. So the first thing I want to, and obviously the main advantage of thoracic ultrasound compared to CT is that it's physician-led, can be easily performed at the bedside, and it's significantly cheaper than CT. So these are three key advantages of why ultrasound has really helped us move the field forward. So these are the main diagnostics that we look for when we identify, when we assess pleural effusions. We're looking for echogenic swirling. We're assessing the diaphragm. Naj, in the previous talk, has already spoken about some of the features that you can find with regards to the diaphragm. It helps us identify septations and pleural thickening as well. So this is echogenic swirling. You can see this movement. You can see the movement here within the. Can we change it into a laser or no? Okay, that's fine. So this move, oh, there we go. Yeah, you can see the swirling here going within the fluid. And this is usually a marker of echogenic protein debris within the fluid that can often was used to be thought of as indicating that the fluid was an exudate. However, my colleague Rachel Ashak performed this study, prospective study of echogenic swirling in 140 patients. And what she found that the positive predictive value was 90% of echogenic swirling. So still 10% of patients will have echogenic swirling, but they won't necessarily be exudates. So clinical decision-making shouldn't be changed purely based on the echogenicity, but if you do find echogenic swirling, it does suggest that you do need to perform a diagnostic tap to take a sample of the fluid and send it for further analysis. Again, if we look at other important features that you can see on ultrasound, these are nodules here you can see of the diaphragm. On the far image over there, you can see evidence of parietal, craggy, irregular-looking pleural thickening. This looks very suspicious. This is a picture that is highly suggestive of involvement of pleural malignancy. So how good is ultrasound compared to the Lyon criteria, which I mentioned to you in the previous section of the talk. This was a study led by Qureshi et al., published in Thorax, again, significant time ago. This was 52 patients. They did thoracic ultrasound before the diagnosis was established. They then compared it to the CT scan, and the final diagnosis was established on thoracoscopy. And what you can see is that in terms of parietal pleural thickening, the specificity was higher in ultrasound. In nodular pleural thickening, it was when in the presence of nodular pleural thickening on ultrasound, it is significantly better than on CT. Additionally, there are 3 or 4 different criteria that you cannot assess on CT, particularly relating to visceral pleural thickening, diaphragmatic thickening, assessment of the diaphragmatic layers and nodules, that ultrasound really allows you to do where CT cannot do. So overall, you get significant improved sensitivity and specificity on thoracic ultrasound. This is another example of an ultrasound where you can see there was some diaphragmatic nodularity and a structure coming out of the costophrenic angle, and this is exactly what it looked like at thoracoscopy. So the ultrasound picture correlates very well with what you see in thoracoscopy. What about these? These are septations. A lot of you will have seen these. These are locules that form related to increased fibrin in the pleural space, often suggestive of infection, however, not always. This is a very good study published in Thorax in 2017. What the authors did here was they compared ultrasound, CT, and chest X-ray with regards to the diagnosis of pleural infection specifically. So the diagnosis, not the prognosis, the diagnosis of pleural infection. And this was retrospective. This was 66 patients who had all 3 modalities, and what they found that ultrasound was superior in both specificity, positive predictive value, and the likelihood ratio of the patient having pleural infection. So ultrasound is really the key when you want to diagnose a pleural empyema. So, however, one of the key things to know about is that the locules can have different pH values. So if you sample this locule, you may get a pH of 7.4, you may get a pH of 6.4 here, and if you aspirate 7.2 there, and if you aspirate down below, you could get frank pus. So it's important to understand the limitations of the pH, which is the major test that we talk about, and I'll cover this in a little bit more detail when I do my pleural infection talk tomorrow. So finally, my final section, how am I doing for time? In terms of improving safety and intervention, now, most of you in the room will see this chest X-ray and will say that this is most likely a right-sided pleural effusion, and you wouldn't be wrong for thinking that. However, one of the key things that ultrasound has taught us is that this is not always the case. And in fact, this was not, this was a patient with severe pneumonia with a very small amount of pleural fluid, but this was a patient who had what we call gray hepatization, where on ultrasound you see pneumonic consolidation, which looks very similar to the liver. And if you're not able to interpret this correctly, you can cause a lot of harm. And when it goes wrong, it can go very wrong indeed. This is a 20 French trocar drain going into the spleen of a patient. And what is interesting is in this case report is that the operator actually used ultrasound when they inserted the drain. So this brings us to the key second point of thoracic ultrasound, which is training and understanding your own limitations with regards to your interpretation of the ultrasound is really important when you're performing intervention. So these are 2 really key points there. Interventional safety, what is the evidence? All of us in the last 20 years, I remember when I was starting as a house officer back in 2008, Mother will remember this very well as well. Everybody was saying, oh, you know, ultrasound, this is, you know, you guys are making a big deal. We've never needed this before. We used to do interventions all the time. You know, what harm can you do with a small green needle? It's just a small needle in the chest. The surgeons were saying, oh, this is rubbish. This is a waste of my time. I don't have time to learn this. You know, I can deal with any problem that I might cause. So what happened was in the UK, we did a survey of 100 trusts. So a trust is a small group of hospitals that cover a specific city. And what they did was they looked at all the critical incidents that were related to chest tube insertion. And if you look at these figures, these are quite scary. So lung or chest wall injury, 17% fatal, 8 deaths. Wrong side, tube going, 2 deaths, 33% fatality. Lost wires, drains going into organs or major vessels, 23% fatality. So these were patients who were dying as a direct result of the procedure that was being formed rather than the disease that they had. So this was very serious indeed. So this led to a national patient safety rapid response report. And obviously since then, the practice has changed dramatically, and thoracic ultrasound is now a mandatory training requirement for any respiratory trainee and anybody that performs any pleural procedures or interventions. And actually, if you look at the evidence for this, I'll just share you this one study. This was a study where conducted in South Africa, and what they did was they asked physicians to mark the site clinically without ultrasound first. They proposed 67%, 172 of 255 sites. The rest they said they could not mark. They then checked with ultrasound. 15% were completely inaccurate, and 70% of those 15 were actually directly over an organ. And half of the unmarked cases were possible with an ultrasound. And actually, it did not matter if a very senior, experienced physician like Dr. Mudar al-Khairallah or a senior house officer performed the percussion. It didn't make any difference. So clinical experience didn't matter, basically. But what thoracic ultrasound did was increase the yield and reduce the risk of solid organ puncture, even in experienced physician hands. Again, this is a similar study where they compared the thoracentesis performed with and without ultrasound. And what they found was that the rate of pneumothorax post-procedure dropped by 20% when you used thoracic ultrasound. So it reduced the cost of care as well, because these patients didn't need to be admitted to hospital and have further interventions for their complications. Added diagnostic information we've already spoken about. And the key thing is that this must be done at the bedside, because complication rates with remote marking, so if I scan the patient here and do the procedure downstairs, that is similar to me doing it without having done any guidance at all. Real-time intervention, just very quickly, thoracic ultrasound allows us to perform difficult procedures that we wouldn't be able to do with direct guidance. So this is small effusion, and what I'm doing here is I'm putting the drain in under real time. I'm watching my wire go in, so I know that I've gone exactly into the pleural space where I want to go. Biopsy as well. So this was the randomized study of 50 patients. This is basically the study that ended Abrams biopsies, which you will all be very familiar with. This was performed by Professor Nick Maskell, who works in Bristol with Steve. And what this was a randomized study of 50 patients comparing. So these 50 patients had negative pleural fluid cytology. They then proceeded to biopsy. They were randomized to either Abrams biopsy or a true cut cutting needle biopsy, and the sensitivity was 47% with Abrams biopsy and 87% with the true cut biopsy. So Abrams biopsy is now no longer performed in the UK at all, and the ability of us to use real-time ultrasound has allowed us to be able to do this. So what are the indications very quickly? Pleural thickening, as we discussed. If a patient is not suitable for thoracoscopy, or if they have a pleurodesed space, then we can use image-guided biopsy, or if they're not well enough to have a local anesthetic thoracoscopy. And this is the needle, just to show you the technique again, going through. And you can watch your needle go straight in and take the sample that you want. And this is my very last section. So again, this is just some of the evidence that shows that even in physicians' hands, this is just as good as whether it's conducted by radiologists as well, with very similar sensitivity rates. Sometimes, however, complications do happen. This is an intercostal artery. Sorry. This is a post-biopsy intercostal artery bleed, and you can see this was caught on thoracoscopy here. And this actually did resolve with conservative management, so it did not require any significant intervention, but these complications can be quite serious when they do occur, thankfully rare. And this brings us to my very final section of my talk, Mudar, which is intercostal vessel screening. Why is this important? Because this study published over 10 years ago showed us now that the intercostal artery can actually take a very different course across the intercostal space, depending on age and depending on other factors within the patient. So what it does is it increases the risk that when your needle goes through, it can puncture a vessel. So we used to always think that if you go more laterally, you're in the so-called safe triangle, that you're okay in terms of causing complications. But in some patients, the intercostal artery can be exposed up to 8 centimeters laterally. So that's clearly why ultrasound is really important. important. And so what they found was that the eye exposed was within the intercostal space within 6 centimeters, and significant variability associated with the age and rib space that you choose. So I conducted this study as when I was in Oxford, and what we did was we scanned patients. We screened their pleural spaces before we conducted any interventions, looking for the intercostal vessels using Doppler. And what we did was any site that was having an intervention, we would mark where the intercostal vessels were. And then this was the technique that we used. It was a very simple screening technique using the same probe that we were going to use to actually perform the intervention. So this was not a radiologist, and this was not a specific probe. This was the same probe that we were using to scan the curvilinear probe. And what we found was that out of 600 procedures, in approximately 53% of them, we were able to identify the intercostal artery, and actually it altered the site that we were going to go in the first time by about 30%. So that was a 30% site alteration rate, and in a significant minority, so 2.5%, the procedure we felt was not safe to be done. So in summary, ultrasound and CT are currently, I think, the core modalities for pleural disease. Ultrasound is really the main workhorse. When we use it regularly, you wonder how you ever did not have it to begin with. Both can be used significantly to improve diagnostic yields and safety, but do remember that each does have its limitations, and adjust the modality to the question being asked. And I thank you all for your attention.
Thank you. Thank you very much, Dr. Eihab.